Now the first cranial nerve is the olfactory nerve, or the nerve that we use for our smell. The first thing we do is demonstrate that the nose is patent. Please sniff. In this case, his nose is patent, so we can carry on with the examination. In order to examine for smell, we should blind the patient, i.e. ask him to close his eyes. Please close your eyes, and can you press on the left side of your nose? And please sniff. Can you identify the smell?
Lemon.
We usually identify 4 different smells with each nostril. We can use household items like fruits or cloves that are pungent, or perhaps soap or perfume. Materials that are readily at hand. The next cranial nerve is the optic nerve, probably the most important of all the cranial nerves. It has 3 components that we test for. The first one is visual acuity, or how well we see. The second one is visual fields, that we see in all directions. And the third one is that the doctor sees well. The doctor can look in the back of the eye and with an ophthalmoscope and inspect the optic nerve. Can you see all right? Do you have any difficulty with vision, or do you wear glasses?
I wear glasses.
And do you wear them for reading, or do you wear them on a day-to-day basis for looking at everything?
On a day-to-day basis for everything.
Well, today we'd like to test your visual acuity, and to test your visual acuity, you should wear your glasses, in this case. Saki, I'd like you to put your toes to the line. This line is 6 meters away from the chart on the wall, and I'm going to ask you to identify the letters in some of the lines of this chart. I'm going to test each eye individually, so please cover your right eye. Now, with your left eye, identify the following letters.
Z, J, P, E, A, O, U, D, P.
I'd like you to cover your left eye. So with your right eye, please identify the following.
X, C, P, N, D, P, J, O, U, D, P.
His vision, according to the Snellen chart, is 6/5. What that means is that he can see at 6 meters, something that a normal person can only see at 5 meters. In other words, his vision is actually better than normal with glasses. Let's say that Saki couldn't see the big number here, which is N. Please take a seat. So the next step then is to determine if he has any vision at all in his eyes. In order to do that, we can ask Saki to identify fingers. Please tell me how many fingers you can see.
2,
How many fingers you can see.
3,
He now can count fingers at 1 meter. Let's imagine he couldn't even count fingers at 1 meter. Our next step would be as follows. Saki, I'd like you to tell me when you see my hand moving. Saki correctly identifies hand movements. Let's imagine he can't see hand movements. Please look at me. Can you see a light?
yes,
Can you point to the light? So Saki, vision is impaired, but he's able to see light. The next step with examining the optic nerve is to check that Saki sees in all directions. That is visual field testing, and it's called confrontation. I'm seated 1 meter away, and I elevate my hands to the horizontal position, and then, Saki, I'd like you to identify where you see my finger moving. Please remember, when you test the eyes by confrontation, you only test the temporal visual fields. In order to test the nasal visual fields, you have to test each eye individually. Saki, I'd like you to cover your right eye. The examiner also covers his corresponding eye, which is his left eye. Please look at my right eye and tell me when you see my finger moving. So in order to test for visual perimetry, you have to come from behind the patient's visual fields, and we do that in convex arcs, as it were from northeast to southwest, from northwest to southeast, and also in the reverse direction. We do it in the following manner. Tell me when you see my finger moving. Tell me when you see my finger moving. Tell me when you see my finger moving. And tell me when you see my finger moving. We ask the patient, please look in the distance. Now, you hold the ophthalmoscope in the right hand, and you approach the patient from approximately 30 centimeters away. The important thing to remember is that you approach the patient in the same horizontal line as the patient's visual axis. That means in the direction the patient is looking. You hold the ophthalmoscope in the right hand, and you look in the right eye. When you look through the lens of the ophthalmoscope, you will see a red pupil. That's called the red reflex. The light is being reflected from the retina. That is normal. You look through the ophthalmoscope and you approach the patient, and you move to within 2 centimeters of the patient's right eye. And you will be able to focus on the optic disc, and then moving the light around the retina, you'll be able to see the blood vessels and the retina. And the next cranial nerves together are the nerves that are responsible for eye movements. Between those two nerves, we examine the pupillary reflexes. The reason for that is that the afferent arc of the light reflex is in the optic nerve, and the efferent arc is in the oculomotor nerve. So this is where pupillary reflexes are examined. There are 3 pupillary reflexes. There is the light reflex, there is the accommodation reflex, and the consensual response. Saki, I'd like you to stare in the distance, and with a bright light in your right hand, you shine a light on the patient's forehead, just at the bridge of the nose. The reason is that you want to inspect the pupils at rest. And in this situation, Saki's pupils are equal, central, circular and symmetrical. At rest. In order to test for the light reflex, you test it in the following manner. You hold a bright light and you bring the light in from behind and shine it on the pupil and look at the response of the pupil to the bright light. In this case, Saki's pupil has reacted briskly. In order to test for the consensual response, you just repeat the maneuver for the light reflex in the same eye as follows. This time you look for the response in the left eye. In order to test for the accommodation reflex, you just very simply ask the patient to stare in the distance. Saki, please look in the distance. You elevate the eyelids slightly. Hold your fingertip approximately 10 centimeters away from the patient's nose. Saki, please look at my fingertip. If you look carefully, both eyes adduct and the pupils constrict. That's a normal accommodation reflex. The next cranial nerves are the nerves responsible for eye movements. There are three: the oculomotor, the third nerve, the trochlear, the fourth nerve, and the abducens, the sixth nerve. These eyes are tested together. The first thing we do is inspect for any unequal eye position or abnormality in eye position, or anything else that strikes you. Secondly, ask the patient, do they have any double vision? Do you have any double vision?
No.
No. Then we test for intact eye movements. Before we do this passively, we always ask the patient to move their eyes as follows. Saki, I'd like you to look up, look down, look at me, look to the right, and look to the left. In order to test for eye movements, we make a H sign in the air and ask the patient to follow it with their eyes. We do that in the following manner. Please look at my finger. Move to the right, up, down, back across the horizontal, and up and down. So a simpler version for testing eye movements is to trace a cross sign in the air. We do that in the following manner. Saki, please look at my finger. Look up, look down, and look right and left. Please remember, when using the sign of the cross method to test for eye movements, that this does not test for the trochlear or the fourth cranial nerve. The H sign method does. The next cranial nerve is the fifth cranial nerve. Now, the fifth cranial nerve is responsible for sensation on the face and the mouth, at least the anterior 2/3 of the tongue, and it's also responsible for motor function. That is mastication. So to test the fifth nerve, we start our examination by testing for sensation on the face. The fifth nerve has three divisions, the ophthalmic, the maxillary, and the mandibular. Very simply, we touch in each division, comparing right and left. Saki, I'm going to touch you on the face, and each time you feel me touching you, I'd like you just to say yes. I'm going to ask you to close your eyes. When you feel me touching you, say yes.
Yes. Yes. Yes. Yes. Yes. Yes.
The next part of the trigeminal nerve is motor. In order to test that, we ask Saki to open and close your mouth. Move it from side to side. That is normal. Now I'd like to oppose the movement. Saki, please open your mouth. He's able to overcome me. Keep your mouth open and close your mouth. That's normal. And push my thumb away with your chin and my thumb away with your chin. Saki is able to overcome my passive resistance of his movement. Please remember that the corneal reflex is not tested in a routine neurological examination. With the fifth nerve comes the corneal reflex. The corneal reflex involves two cranial nerves. The sensory arc is the fifth or trigeminal nerve, and the motor arc is the seventh or facial nerve. It is usual to test it in conjunction with the examination of the trigeminal or fifth nerve. The first thing to do is to hold the lower eyelid down in the following manner. Ask the patient to look up. Then you approach from below, which is outside the patient's visual field, so he cannot see. And then very briefly you touch the coloured part of the eye or the cornea and observe for blinking in the following manner. You observe for the reflex, which is eye closure. That should be bilateral. In Saki's case, his blink reflex is normal. The next nerve is the seventh cranial nerve. And the seventh cranial nerve is responsible for facial expression, but it's also responsible for special sensation to the anterior two-thirds of the tongue. That is taste. Today we're going to examine both its motor function and its specialized sensory function. So we inspect for facial asymmetry. And it's important to look at the forehead, look at the eyelid, look at the nasolabial fold, look at the corner of the mouth, and look at the chin, and compare both sides. So the next step then is examination of the motor function of the facial nerve, which is checking for facial expression. Very simply, this involves three simple one-step commands as follows. Saki, please look up. In this case, he demonstrates symmetrical wrinkling of his forehead. Please close your eyes. He closes his eyes fully, and in some occasions we can test for eye closure by trying to open them as follows. He's able to resist that, therefore eye closure is normal. The last area involves the mouth. Saki, please smile. In this case, movement of the lips is symmetrical. We can also ask him to blow out his cheeks. And we can test for tension in his cheeks in the following manner. In this case, the motor side of his facial nerve is normal or intact. In order to test for taste, we usually use two modalities, sugar and salt, because they're easily at hand. Today I'm going to test Saki's taste in the following manner. I'm going to apply a flavour to your tongue, and I'd like you to identify what it is. Please close your eyes, open your mouth, and put your tongue out.
Sugar.
Yeah, Saki has correctly identified sugar as the flavour. Saki, please close your eyes, open your mouth, put your tongue out, and identify the flavour. So, Saki has correctly identified the flavour. The cochlear nerve has two components, one for hearing and the other for balance. Today we're only going to test hearing. Saki, is your hearing normal?
Yes.
You have no difficulty with hearing?
No.
Let's imagine that Saki has difficulty with hearing. We have to determine whether the hearing is a problem in both ears or just one ear. We're going to test your hearing, and I'd like you to cover your left ear in the following manner. Now, I'm going to make a noise outside your right ear. I'd like you to tell me when it stops.
Stop. Stop. Stop.
So let's imagine that Saki has difficulty in hearing in his right ear. We can determine the degree of hearing loss by moving behind him in the following manner. Saki, I'd like you to repeat after me what I'm saying. Please cover your good ear or your left ear. Okay. And from approximately 1 meter behind the patient, you whisper. Please repeat after me.
1, 2, 3.
Saki has normal hearing, but let's imagine that he's still unable to hear. The next step is to speak it. Please cover your left ear. 1, 2, 3.
1, 2, 3.
Let's imagine he still can't hear. The next step is to shout it. 1, 2, 3.
1, 2, 3.
And in that way we determine the degree of deafness. To demonstrate the Rinne test, you just place the beating tuning fork over the patient's mastoid bone and you ask the patient, please tell me when you stop hearing it.
Stop.
Then you place the beating tuning fork outside the ear canal. Do you still hear it?
Yes.
In this case, air conduction is greater than bone conduction, and that's normal. That's a normal Rinne test. Let's imagine that wasn't the case. That Saki heard best here. Tell me when it stops.
It stopped.
And we place it over the externally here. Now let's imagine you can't hear it. That would mean that bone conduction is greater than air conduction. That would indicate conductive deafness. In order to do the Weber test, you take a tuning fork, you make it vibrate, and you place it in the midline, usually on the top of the forehead, and ask the patient, Saki, which ear do you hear that best in?
Both ears.
That's a normal Weber test. The next cranial nerve is the glossopharyngeal nerve. And the glossopharyngeal nerve is responsible for normal sensation for the posterior part of the tongue and the fauces. And it can be tested by doing the gag reflex. However, a reflex arc involves both sensory and motor function. And therefore, we test the 10th cranial nerve, or the vagus nerve, when we do the gag reflex. In order to demonstrate the gag reflex, we do it in two ways. The first is voluntary, and the second is involuntary. The voluntary gag reflex is demonstrated as follows. Saki, please open your mouth wide. Put your tongue out. Now we shine a light on the soft palate. Please say "ah." Again. In this case, Saki's uvula elevates in the midline symmetrically. That's a normal voluntary gag reflex. However, to test an involuntary gag reflex, you have to touch the soft palate. And the way we do that is as follows. Saki, please open your mouth, put your tongue out, and then you shine a light on the soft palate, and then you touch it. When I touched it, it moved. And that means that it is normal on that side. We do the same on the other side. In that way, we've actually tested the glossopharyngeal nerve. So in order to test the accessory nerve, we do it in the following manner. First, we do inflection. And we look for wasting or any other abnormality that is obvious. We do that from the side and from the front and from behind. And there's no obvious wasting in either the sternomastoids or the trapezius muscle. The next step is to test for power. We do that in two ways. One, by asking the patient to move his head. So Saki, can you please turn your head to the right, to the left, come back to the middle, and can you flex your neck or bend your head down? In all situations, the movement is normal. We can now oppose that movement in order to test his power. Saki, please push my hand away to the right, and you see his left sternomastoid standing out, which is normal. Please push my hand to the right, and on this occasion you see the right sternomastoid doing the same thing. Please come back to the midline. Now push my thumb away, and you see both sternomastoids contracting. That means his sternomastoids are normal. In order to test the trapezius, we go behind the patient and ask the patient to shrug his shoulders. Please shrug your shoulders. Then we resist that movement by placing my hands in this manner on his shoulders. Please elevate or shrug your shoulders. And he's able to push me away. Saki's accessory nerve is normal. The 12th cranial nerve is the hypoglossal nerve. It's a motor nerve and is responsible for movement of the tongue. We're going to inspect the tongue. We do it in two positions, at rest and protruded. Saki, please open your mouth. Shine the light on the tongue. Put your tongue out. Put your tongue in and out slowly. Then put your tongue in and out rapidly. Close your mouth. place your thumb against your cheek, push my thumb away, and do the same on the other side. And we look for any obvious abnormalities such as wasting, fasciculation, or any other abnormalities that strike us. The upper limbs are examined usually in the seated position. And today we're going to start with the upper limbs. The order of examination is always the same for both upper and lower limbs. It starts with inspection, then we do tone, then power, then coordination, then reflexes, and lastly sensation, in that order. On inspection of the upper limbs, having exposed the limbs and our patient in the seated position, we inspect them. The inspection involves the hands, the forearms and arms. We look for the following: muscle wasting, fasciculation, or what we call muscle fiber twitching, abnormal posture, abnormal skin markings, or any other deformities that strike us. We examine the limbs effectively in two positions. The first position is the prone position. Can you place your hands on your knees? And we look carefully for any obvious wasting or the things that I've said. Then you ask the patient to turn the hands over and look in the supine position, particularly for wasting of the small hand muscles, the thenar eminence, the hypothenar eminence, or the small muscles of the hand, the forearm, and the arm. In this case, Ben's examination is normal. The next part of the examination of the limbs involves tone. The most important part of this examination is to relax the patient. So you get the patient in a comfortable position. Are you comfortable, Ben?
Yes.
Yeah. And in the upper limbs, we examine tone at the elbow and the wrist, feeling for resistance. We bend the arm or flex it fully and extend it fully in a passive manner, all the time looking at the patient's face so that we know if we're causing any pain. I'll repeat that maneuver. We flex and extend the elbow fully. In this case, tone is normal. The examination is continued at the wrist. In this case, we look at the patient's face and bend the wrist backwards and forwards, feeling for resistance. In this case, there is no resistance. Ben's tone is normal. Finally, we can do another maneuver which is called supination and pronation. Again, testing for tone and checking for passive resistance. In this case, supination is normal and pronation is normal. So after inspection and tone comes power. This is often the most difficult part of the examination of the upper limbs for students. It's very important to remember that you should test for power actively before you test for it passively. By actively, I mean getting the patient to do as much as they can first. Ben, can you elevate your arms over your head? In this case, Ben's power looks normal. Remember, always test for power first proximally in the shoulders and then in a proximal to distal direction. In order to begin the examination for power in the upper limbs, we instruct the patient to take his elbows out from his sides. Ben, please take your elbows out from your sides and hold them up in that position. I'm going to press down on your elbows. Please push up and resist my movement. He's able to fully resist any attempts to press his elbows down. Abduction is normal. test for power at the elbow, we ask the patient to hold the arm with the elbow flexed at 90 degrees. Then hold your arm up in that position. Very good. To test for flexion at the elbow, then please pull against me. And this is normal. We can see the biceps contraction. Push against me. Extension at the elbow power is normal. Please hold your arm out straight with your fist closed. Now don't let me push down. I'm checking for extension at the wrist. Now I check for extension of the fingers. Push up against me. Turn your hand over and make a fist. And don't let me straighten your fingers. Hold your hand out straight. Don't let me push in against you. Okay. And you press in this manner. Hold your hand in that position. Bring your thumb up towards your face. Now push against me. And he's able to resist the movement. Test for thumb abduction as illustrated. So Ben, are you comfortable?
Yeah.
We're now going to test for coordination in the upper limbs by using the finger-nose test. So Ben, I'd like you to hold your right arm out fully stretched away from you in a horizontal position. With your eyes open and looking straight ahead, I'd like you to touch the tip of your finger to the tip of your nose. So do that slowly. Repeat that again for me. Now we'd like you to do the same on the left side. And repeat it a little faster. So that's sufficient. If we suspect there is any coordination, we can make the test more difficult for Ben by the following maneuver. Ben, I'd like you to touch my finger and then touch your nose and touch my finger again. Touch your nose and touch my finger again. We can even make it more difficult by Ben by moving my finger. So Ben, please touch my finger, touch your nose, touch my finger, touch your nose, touch my finger, touch your nose, touch my finger, touch your nose. Watch for accuracy and repeat the test on the other side. The next part of the examination of the upper limbs involves testing for reflexes. In this part of the examination, it is very important that the patient should be relaxed. In this case, Ben looks relaxed. It's also important to flex the arm to 90 degrees. You place your index finger over the biceps tendon and you tap it. In this case, you can see that his forearm is contracting. To test for the triceps jerk, you hold the forearm in the flex position and tap the triceps tendon. And here you see a brisk reflex. The final reflex is the supinatal reflex. You leave the arm in the same flexed or semi-flexed position as you did for the biceps jerk. You place your fingers over the forearm in the following manner and you tap. And you look for a slight contraction in the forearm. To demonstrate reinforcement in the upper limbs, it's important to be able to distract the patient. The way we do that is ask the patient to grimace or concentrate on his jaw muscles. Then, can you make with your teeth? Now he's distracted. I can now tap his biceps jerk again, And in this case, you see a slightly more obvious reflex. We do the same with the triceps. Again, slightly more obvious reflex. And now the supinator. And in this case, probably a more obvious reflex. If reflexes are absent, please check by repeating the reflexes with the patient reinforcing in the manner that I've demonstrated. The last modality of examination of the upper limbs involves sensation, and in some ways this is often the more difficult part of the examination. The reason is that the information now has to go through the patient. Therefore, we must communicate clearly with our patient. It's also important that the patient be relaxed and the patient understand what you're trying to do. Always test for sensation, first distally in the fingers and then in a distal to proximal direction. In testing for sensation in the upper limbs, it's important to ask the patient, have they any loss or alteration in sensation? Then, have you lost any sensation in your hands or your arms or your forearms?
No.
No. Ben, I'd like you to say yes when you feel me touching you.
Yes. Yes.
Ben is now trained. Now Ben, I'm going to test sensation in your upper limbs, beginning with your fingers, but I'd like to do it with your eyes closed. When you feel me touching you, please say yes.
Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes. Yes.
So Ben, was there any difference between the right and the left side?
No.
And did you feel the sensation was as strong on your fingers as it was on your arms?
Yes.
Ben's sensation is normal. We've just demonstrated light touch, which is an example of superficial sensation. We could also have tested pain and hot and cold. Now we're going to move on to deep sensation. Deep sensation has two modalities. One, joint position sense, and two, vibration sense. I'd like to demonstrate joint position sense. I'm going to move your fingers up and down, and I'd like you to tell me which direction they're moving in. This is up, and this is down. But I'd like you to close your eyes when I'm doing it. I'm going to start the examination. The important thing is to remember that you have to grip the distal part of the finger at the sides, not at the top and bottom. Now, which direction am I moving it?
Up. Down.
Let me check the other side, please, the left hand.
Down. Up. Up.
You can open your eyes. So Ben's joint position in his upper limb is normal. The other modality of deep sensation that we routinely test for is vibration sense. In order to demonstrate vibration sense in the upper limbs, we have to do it as follows. Then, I'm going to put a beating tuning fork on your collarbone. I'd like you to tell me when you feel it. Okay? You can have your eyes open. Do you feel that now?
Yes.
Okay, now close your eyes. Tell me when it stops.
Stopped.
So Ben is now trained and knows what to expect. I'd like to continue now with the examination involving his upper limbs. Ben, I'm going to test vibration sense in your fingers, your hands. Taste the vibration. Do you feel that?
Yes.
Tell me when it stops.
Stopped.
Please give me your left hand. Feel it?
I feel it.
Tell me when it stops.
Stopped.
If vibration sense was absent or diminished in his fingers, I would move to a proximal bony point, which would be the metacarpophalangeal joint, or the wrist joint, or the elbow joint, or indeed the shoulder joint. To proceed with the examination of the limbs, we now move on to examination of the lower limbs. The order of examination is identical to that in the upper limbs. It involves inspection, tone, power, coordination, reflexes, and sensation in that order. We begin with inspection. In this case, we have to make sure that the thighs and the legs and feet are fully exposed. Except the difference is the patient is now in the lying position. In a similar manner to the upper limbs, we look for any obvious wasting or fasciculations or deformities or any other abnormalities of posture or skin that strikes the examiner. So the next part of the examination of the lower limbs involves tone. It's very important that the patient be relaxed, and tone is tested mainly at the knee and the ankle, also sometimes at the hips. The way we test tone is we move the joints passively through their full range of movement in the following manner. Testing tone at the knee, we move the leg passively in full flexion and full extension, feeling for the degree of resistance and at the same time looking at the patient's face to make sure we're not causing them any pain. The maneuver is repeated on the other side to compare and contrast. In a similar manner, I test tone at the ankle. We flex the knee to 90 degrees, we flex the ankle very slightly, and then flex and extend. All the time feeling for a degree of resistance and inspecting the patient's face. And please remember to compare and contrast to the other side. At the ankle, we sometimes check for clonus, especially if the tone is increased. Clonus is checked for in the following manner. Flex the knee to 90 degrees, put gentle pressure on the ankle, and then a quick movement, and feeling for the presence of repeated clonic action. Finally, we can test for tone around the hip joint by rolling the knee in the following manner. Feeling for resistance. The next part of the examination of the lower limbs involves testing for power. Similar to the upper limbs, it's very important to ask the patient to actively do as much as they can before you examine power passively. Ben, I'd like you to lift your leg off the bed. Your right leg first, very good, up as far as we go, and left leg, very good. Now we can start examining for power. It's very important to remember that power is tested in a proximal to distal direction. This is in contrast to sensation, which is always tested in a distal to proximal direction. Then I'd like you to lift your right leg up off the bed. So testing for flexion of the right hip joint, in this case, power is normal. Flexion at the hip joint involves the quadriceps muscle and the femoral nerve roots L3 and 4, and also iliacus and psoas muscles, femoral nerve roots L1 and 2. Ben, I'd like you to push down into the bed against me. Push down, please. And here he's able to resist my movement. That means it's normal. Another way I can demonstrate it is ask him to push his heel down into the bed. Push your heel down into the bed. I'm now testing him for hip extension. Hip extension is innervated by the sciatic nerve and nerve roots L5 and S1. Moving down to the knee joint, and bend your knee. Now I'd like you to straighten your knee, or straighten your right leg. Ben is fully able to straighten his right leg against me. This involves testing the quadriceps. The quadriceps is supplied by the femoral nerve and involves nerve roots lumbar 3 and 4. Proceeding with the examination of power in the lower limbs, we're now going to check for knee flexion. Ben, I'd like you to bend your knee to 90 degrees. In that position, I'd like you to pull your heel in towards your bottom. Ben is able to pull his heel and overcome any resistance from me. This involves the sciatic nerve and nerve roots L5 and S1. Straighten your leg. Moving on to the ankle, we check for dorsiflexion and plantar flexion at the ankle joint. To begin with dorsiflexion, then I'd like you to bring your toes up towards your face and hold them there. Don't let me pull them down. This involves the common perineal nerve and nerve roots L4 and 5, and in this case it's normal. Then I'd like you to push down against me as hard as you can. As hard as you can. This involves the sciatic nerve and nerve roots S1 and S2. In this case, Ben is able to push me away. That means his plantar flexion is normal. So in addition to plantar and dorsiflexion of the foot, we can sometimes test for dorsiflexion of the big toe, which is specifically innervated by L5 nerve root. Ben, I'd like you to bring both big toes up towards your face and hold them there. Right up, please. Keep them up. Don't let me pull down. And again, Ben is able to resist me pulling the big toes down. In this case, power is normal. To continue with the examination of the lower limbs, we test for coordination. Again, the patient is in the lying position, and we ensure that the patient is relaxed. Ben, I'm going to test for coordination in your legs. I'd like you to do the following maneuver. Can you hold your right leg up in the air? Place your right heel on your left kneecap. Run it straight down your shin. Now I'd like you to repeat the maneuver on the left hand side. Do exactly the same. Hold the left leg up in the air, place your left heel on your right kneecap and run it down your shin. We look for any evidence of incoordination or unsteadiness. So the next part of the examination involves checking for reflexes. The patient is still in the lying position and we have to ensure the patient is relaxed. In order to elicit the reflexes in the lower limbs, we tap the quadriceps and the Achilles tendon, and then we check for what's called the plantar reflex. Before we elicit the knee reflex, we should palpate the quadriceps tendon. The quadriceps tendon is situated between the patella and the tibial tuberosity. Ben, I'd like you to bend your knee to 90 degrees, and then you feel for the quadriceps tendon there and you tap it. I find it easier to elicit the knee reflex while supporting the thigh in the following manner. And I tap the tendon like this, and here you see a brisk knee reflex. Usually it is not necessary to tap a reflex more than twice. So in order to demonstrate the ankle reflex, it's very important to get the patient in the proper position. The proper position is as follows. Ben, please bend your knee, and I'm going to bring his ankle and place it across his right leg in the following manner. Please note that his knee is flexed to 90 degrees and his ankle is flexed to 90 degrees. Now, with very gentle pressure on the foot, you tap the Achilles tendon in the following manner. And here you see a brisk reflex. I'll repeat the reflex for you. And here you see a brisk contraction of the foot, and that means his ankle jerk is intact. The ankle reflex can be demonstrated in two alternative positions. Sometimes that's necessary, perhaps when they're absent, or the patient is unable to move for whatever reason. The two other positions are kneeling, with the feet extended over the edge of the couch, or lying flat with the legs fully extended. I'll demonstrate the ankle reflex in the extended position. Just placing your hand firmly on the sole of the foot, slightly flexing the ankle to 90 degrees, just tap briefly on your fingers, and here you see a very mild contraction or an intact reflex. The other side, in a similar manner, it's demonstrated. Just as in the upper limbs, if the reflexes in the lower limbs are absent or reduced, or you're in doubt about them, it is important to ask the patient to reinforce. The way we reinforce in the lower limbs is not the same as the upper limbs. Ben, I'd like you to put your two hands together and pull them apart in the following manner, but don't do it until I tell you. Now, Ben, pull. Now I will check the ankle reflex in this position and watch. And here you see the ankle reflex is more clearly visible. It's important to check for reinforcement before you say reflexes are absent. The last reflex in the lower limbs is the plantar response. This is probably the most important reflex in the body, and sometimes the most difficult for medical students. I'd now like to demonstrate the plantar response. The normal plantar response is downgoing. By that I mean the first movement at the metatarsophalangeal joint is flexion. In order to elicit the plantar response, you take a blunt instrument, usually a key, and you stroke the outside of the foot very firmly, coming across the metatarsal heads and finishing between the first and second toe in the following manner. The reflex you're looking for is the first movement of the big toe at the metatarsal phalangeal joint. If that movement is downgoing or flexor, it is normal. If it is upgoing or extensor, it is abnormal. The final part of the examination of the lower limbs involves testing for sensation. Sensation is divided up, again as in the upper limbs, into two main groups, superficial and deep. An example of superficial sensation is light touch. We'll test for light touch in a manner identical to the upper limbs. So my patient is already trained. And Ben, I'm going to touch you in the lower limbs, beginning in your feet, and I'd like you to say yes when you feel me touching you. But you must do it with your eyes closed. Please close your eyes and say yes if you feel me touching you.
Yes. 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 Yes.
Ben, was there any difference between the right and the left side?
No.
Was there any difference between your feet and your thighs?
No.
The next modality of sensation we test for is deep sensation. The two tests we use for deep sensation in the lower limbs or legs is identical to that in the upper limbs. It involves joint position sense and vibration sense. I will start with joint position sense. In order to demonstrate joint position sense in the lower limbs, we grab the toe with the thumb and index finger of the left hand, just proximal to the phalangeal joint, and we fix it. Then we move the toe up and down and ask the patient to indicate the direction of movement. Ben, I'd like you to indicate which way I'm moving your big toe. This is up and this is down. Now close your eyes. Which way is that?
Up.
Which way is that?
Down.
Which way is that?
Up.
And on the left big toe, which way is that?
Down.
Which way is that?
Up.
Ben's joint position sense is normal. So the last modality of sensation in the lower limbs is vibration sense. And this also requires the cooperation of the patient. Now my patient knows what to expect because I've tested the upper limbs. And it's not necessary to test it on his clavicle. Ben, I'm going to place a beating tuning fork on your big toe, and I would like you to tell me when it starts and when it stops. Okay?
Okay. I feel it.
Tell me when it stops.
Stopped.
Very good.
I feel it.
Tell me when it stops.
Stop.
Ben's vibration sense is intact or normal. Now we're going to examine your gait. In order to do that, we have to carry out a Romberg's test and to look at you walking. The first thing I'd like you to do is to put your arms by your sides, put your heels together with your toes apart at approximately 10 to 2 position, and then close your eyes. And I just move beside the patient just in case he sways or falls, which would indicate a positive Romberg's test. That would mean that the patient has an ataxia due to loss of feeling for his joint position sense, and when he closes his eyes, he loses his balance. Please note that a Romberg's test is not done routinely. It is done only if we suspect an abnormality in joint position sense. So Ben, we're going to test your gait. And to do that, I'm going to ask you to walk normally with your arms by your side as you would do normally. When inspecting the gait, please look for the following: an abnormal gait, unsteadiness, stiffness, loss of arm swing, and difficulty in turning or any asymmetry. If we still suspect that Ben has an ataxia or an unsteadiness, we can make it more difficult for him by asking him to walk a straight line with one foot in front of the other in the following manner. So please put your left foot in front of your right foot and walk a straight line. You can look at what you're doing. Very good. And turn around. And again, we demonstrate there's no unsteadiness or ataxia. Finally, we can take his eyes and the rest of his balance out of it by asking him to look straight ahead and not look at his feet and to hold his arms outstretched. So finally, we'd like you to look straight ahead with your arms outstretched in that position and walk in a heel-to-toe manner. And again, we notice no unsteadiness. Please turn around. So Ben's gait is normal. There are a number of abnormal or classical gaits in neurology with which you will become familiar later.